Hello guys, I am Hemant Kagita from Kharkiv National Medical University. Hope you're all having a great time with your books. So it's time to check upon our live session. So here we go. With immense pleasure, I want to acknowledge you all to someone whom we are privileged to have here with us today. So Dr. Thamil Selvi ma'am, MBBS and DCP Diploma in Clinical Pathology, who is currently working in the Transfusion Medicine Department, Meenakshi Medical College, Kanchipuram. Dr. G.M. Tamilselvi ma'am completed her undergraduation from KMC 1995 batch and post-graduation from MMC 2004 batch. And ma'am started to work in the Meenakshi Medical College in the Department of Pathology from 2006 and started to work in transfusion medicine from 2007 December till date. 13 years of service to the society and students like us. We all welcome you, ma'am.
Hi everyone, I'm Dr. Thamil Selvi from Meenakshi Medical College, Department of Transfusion Medicine. I'm very happy to be here with you all in this live session.
Ma'am, can you please tell us what are the topics we are going to discuss in today's session?
Today we'll briefly cover about the blood donation process, which includes the blood selection and blood collection and separation, and about the screening process of the collected blood, and about the compatibility testings and the transfusion reactions, and about the protocols what we are following during the COVID crisis. So we'll try to cover these at least some basics in these topics.
So in the first place, we are going to see the criteria for the selection of donor's blood and how important it is to examine the medical history and also the physical exam for the selection of the donor blood. So let's start, ma'am.
Yeah. Actually, the selection criteria is a vast topic. We'll cover this now. Actually, the blood donation process starts with the donor registration. Actually, it has many steps. It starts with donor entering the blood bank, and you have to collect the pre-donation information from the donor about the awareness of the selection criteria, about any medical illness for the donor, and about any transfusion transmitted infection possibilities in the donor. And then you give the donor questionnaire, that is the donor form to fill. So these are the first two processes when a donor enters the blood bank. So he has to fill the donor questionnaire. And after that, you have a counseling session for the donor. So during this counseling, you have to review the full history card, that is the donor questionnaire. And you have to explain the donor about the adverse reactions, what he can get during the reaction, and about the infectious disease screening in his blood. And if he has any queries, you can explain to them also. That is, if any clarification he needs, you can clarify his doubts. And moreover, all this, you have to explain the confidentiality in maintaining the positive reports. And after getting everything, you have to assess the risk behavior. That is, some donors have high-risk sexual behavior. So you have to verify all this, get the consent of the donor, and then proceed for medical examination. So these are the steps involved in the donor registration. Then about the donor questionnaire. So this involves the selection criteria. So actually certain basic criteria are there. So that this is important for a donor. So initially when a donor comes to the blood bank, so first the donor has to fulfill the basic criteria. So one is age. So the age, so all these are based on the National Blood Transfusion Council, India. So I'm covering this Indian guidelines. So from 18 years up to 16 years. So 18 years is the minimum blood donation, that is the minimum age for donating a blood. And the maximum age limit is 65 years for a regular donor. When the donor is coming for the first time, it's better to restrict the donor at 60. So 18 to 65 for a regular donor, but when a donor is coming for the first time, you restrict the limit at 60, age limit at 60. So this is about the age. Then about the hemoglobin. The hemoglobin must be about 12.5. So for male or female, the hemoglobin limit should be more than 12.5. So the maximum limit is also important. So for a male, the maximum limit should not be more than 18, and for a female should not be more than 70. So within this limit, the donor is eligible for blood donation. So the reason is when it is above these limits, it can be considered as polycythemia. So you should not use that blood. So the maximum limit is also important for a blood donation. Then about the weight. So weight minimum criteria is 45 kg. So standard volume is what we are bleeding is 350 ml. So for donating 350 ml, 45 kg is the minimum, 45 and above is the minimum criteria for donation. But most of the blood banks are collecting 450 also. 450 is also authorized only. So for collecting 450 ml, the donor's weight must be above 55 kg. So these are the weight limits. Minimum 45 for bleeding in a 350 ml bag and above 55 for 450 ml bag. And the other basic criteria is the time interval between two donations. So minimum 3 months duration is mandatory for donating again. So this is important because the cells has to regenerate during this period. So you have to give 3 months duration between two donations. So these are the basic criteria. So apart from this, the donor has to fulfill the medical history, surgical history, the past medical history. So everything should be covered in the question. So basically you have to assess the general physical and mental status of the donor. It should not be under alcohol or that is smoking also. Minimum 24 hours before alcohol intake, and smoking also 6 hours. And about the medical history, at the time of donation, it should not have any fever, allergy, asthma, and any diarrhea, any sort of infection. So it should not be suffering from any kind of infection at the time of donation. And other illnesses, any chronic illness and any systemic illness. The treatment history is very important in blood donation. So you should not collect blood from a donor who is on some chronic treatment. So example, anti-epileptic, anti-tuberculosis, anti-leprosy, and psychotic drugs, antidepressants, and chemotherapy also, radiotherapy, chemotherapy. So steroids, so the most common drugs like antibiotics and steroids, aspirin. So these are common drugs mostly used by so many patients. So this is contraindicated. When a donor is on antibiotic, he has to donate only 14 days after the last dose. So this is very important. And steroids also the same thing. And aspirin also, after stopping the aspirin, 3 days after that only a donor can donate. So the treatment history is very important. So you have to get the history of medical illness and the treatment history regarding the medical illness. And other fevers like dengue and chikungunya. So we have suffered from dengue or chikungunya. After 6 months only, a donor can donate. Like that, other fevers like Zika fever, West Nile fever, for those fevers also, after 4 months he can donate. And any history of malaria, typhoid, and jaundice, after 1 year, a donor can donate. And if the jaundice is due to hepatitis B or hepatitis C, he is permanently deferred from blood donation. But if the jaundice is due to hepatitis A or E, he can donate after 12 months period. So this is about the medical illness. And regarding the surgical illness, any minor surgeries like any dental procedure under anesthesia or any minor surgery, you can donate 6 months after the recovery time. And any major surgeries which involve accident, any RTAs or any major surgery which involves blood transfusion also. So all this they can donate after 12 months after the recovery. So these are the surgical illness which are covered in the donor selection criteria. And vaccination also plays an important role. After any live attenuated vaccine or killed vaccine, they can donate after 4 weeks. But for any immunoglobulin, that is post-exposure prophylaxis, which is given after any animal bite, especially dog bite, or after hepatitis B exposure, a donor can donate only 12 months after the vaccination. And these are common. And for females, you have to ask the menstrual history. During the menstrual period, they cannot donate. And during pregnancy, during lactation, they should not donate during this period. And after abortion also, 6 months after that, they can donate. So this is for female donors. So these are the vast selection criteria covered in this area. And after this, give the consent and go for medical examination. So in medical examination, you have to measure the BP, pulse, CVS, and RS. So the BP, the systolic BP should be 100 to 140, and the diastolic BP range is 60 to 90, and pulse should be between 60 to 100. And if the CVS and RS is fine, you can proceed the blood donation process. So these are the main selection criteria covered in the donor questionnaire.
So guys, till now we got to know what are the criteria for selecting the donor blood, and now we'll know how we'll collect the blood and also how important it is to follow the protocol which is given for us.
Once the donor is selected for blood donation, then the option is whether you can collect in a 350 ml bag or a 450 ml bag. If the donor is a first time donor, better to go with the 350 ml bag. It's either single or double or triple. And if it is more than 55 kg, then you select a 450 ml bag. Then the selection of the type of bag depends on the blood bank's availability, that is stock availability. If you want whole blood, you can select the single bag. So actually the types of bag available are single bag, double bag, triple bag, and quadruple bag. And so many types of bags are available. Pediatric bags are also available for pediatric patients. So generally we are collecting in single, double, triple, and quadruple bags. And I'll show you the bag also, then we'll discuss. Are you people able to see this? This is actually double bag. And so this is the primary bag. So this is the primary bag. That is the bag with the needle is the primary bag. And this primary bag contains the anticoagulant. Can you see the anticoagulant? Some fluid is there inside.
Yes,
so this is the primary bag. And this bag is connected with the satellite bag. So this bag is double bag. So when it is a triple bag, one more bag will be connected to this. If it is a quadruple bag, again, one more bag will be there. So in a quadruple bag, one primary bag with 3 satellite bags. Since this is a double bag, one primary bag with 1 satellite bag. Okay, so this is there is anticoagulant present inside, and the needle is sealed actually, and each bag comes in a separate cover. Okay, so the blood donation process is completely sterile. So each bag comes in a separate cover with sealed needle and all, because some of the donors may think that they'll get infected even during donation. So all these are that is completely sterile process only. Then about the blood bag. So if you collect in a single bag, you can collect the whole blood, that is with the full plasma and RBC, all the components together. When you collect in a double bag, you can separate the packed cell and plasma. So packed cell in the primary bag, and in the satellite bag, you can separate the plasma. In a triple bag, you can collect the packed cell, plasma, and platelet concentrate. So these 3 components can be separated from a triple bag. So if you collect in a quadruple bag, packed cell, platelet, plasma, and cryoprecipitate. So you can collect 4 components in a quadruple bag. So different types of bags. So based on your requirement, you can select the blood bags. And about the anticoagulant present in the blood bag. So this fluid, this watery fluid, the transparent fluid is anticoagulant, which is CPDA. So CPDA is citrate, phosphate, dextrose, and adenine. The citrate is the main anticoagulant, that is trisodium citrate. So trisodium citrate is the main anticoagulant present in the blood bag, along with the phosphate, dextrose, and adenine. Or phosphate is for buffering action to maintain the pH during the storage, and dextrose and adenine is to maintain the ATP level and diphosphoglycerate level. So you have to maintain the blood during the storage. So you are adding all these components in the solution to maintain the viability of the blood cells. Okay, so when you collect blood in this bag, so and the volume is 49 ml. So you are collecting 350 ml from the donor. The blood bag contains 49 ml of anticoagulant. So finally, the volume comes to around 400 ml. So this is the final volume in this bag. So after collection, you have to store the blood bag in the blood refrigerator, which maintains the temperature at 2 to 6 degrees Celsius. So in CPDA, you can preserve the blood for 35 days. So the blood once collected is viable for 35 days. So you can the shelf life is 35 days. So this is only for blood and packed RBCs. And for plasma, it is different. Plasma and plasma as fresh frozen plasma. It's called as FFP. This FFP and cryoprecipitate can be stored for 1 year. So the shelf life of cryoprecipitate and plasma is up to 1 year. And platelet, the shelf life is very short. You can preserve the platelet only for 5 days. And each component, the storage is different and shelf life is also different. Okay, and about the needle is 16 gauge needle. That is a very wide bore needle. Okay, so this is 16 gauge needle. So after selecting the blood bag, you can proceed with the blood donation process. So the time taken for blood donation process is only 5 minutes. That is 5 to 8 minutes. The collection time is only 5 to 8 minutes for a donor. So once the donor comes, the history taking, medical examination, and the collection and the observation time, everything will be maximum up to 1 hour. So this is about the blood collection process.
Yes, ma'am. So, ma'am, after collecting the blood, can we screen any infections which are very important to know?
Collection, whether it's collected as a whole blood or it is collected as a component, either paxil or plasma. So you are storing in the appropriate refrigerator. So the next step after the blood collection is the TTI screening, that is transfusion transmissible infectious disease, that is infection screening. So this has to be done prior to doing the compatibility test. The screening procedure means you are screening for the infections present in the blood bag. So mainly the transfusion transmissible infection only, not for everything. So there are certain infections which can be transmitted through blood. So there are so many infections which can be transmitted through blood. The common infections are HIV 1 and 2, HBsAg, HCV, malaria, and syphilis. So these are the common infections. And in India, these 5 infections are mandatory to be tested before transfusion. And apart from these 5 infections, there are other infections like CMV, EBV, and HTLV virus, that is human tussle leukemia virus, and leishmaniasis. So all this can also, and Creutzfeldt-Jakob disease. So all this can also be transmitted through blood. But those infections are not prevalent in India, so we are not doing the screening for all those infections. We are covering only these 5 infections: HIV 1 and 2, HBsAg, HCV, malaria, and syphilis. And the infection, there are so many methods in doing the screening. You can do by rapid CAR test, by ELISA test, by chemiluminescence method, and recently advanced method like nucleic acid amplification test. So all these tests are available. So after doing the screening and selecting the blood bag, if everything is negative, then you have to place a screening label for the blood bag, and then only the blood bag is suitable for transfusion. So this is the next process after the collection. And one more important thing in the screening is, while selecting the donor also, you have to inquire about the window period. So window period plays an important role. So window period means the person is carrying the acute infection. That is, the patient is recently infected and he may be carrying the virus also. But this is otherwise called a seroconversion period. The person is carrying the virus, but the serological parameters are actually absent in the blood. So you cannot detect any antigen or antibody by any other test during this time. But after 3 months or 4 months, so example, if you take HIV, so previously it was 3 months. After 3 months only, you can detect the positivity. But during this period, even though the person is carrying the virus, you cannot detect by the ELISA test also. But now recent tests are available. Now the window period has been reduced. Now by recent ELISA, you can detect in 2 weeks to 4 weeks also. And another advanced test called nucleic acid amplification test, you can detect the HIV in 3 to 5 days also. So the main thing is, during this window period, if a donor donates, the test result may be false negative also. So that's what you are asking, the high-risk sexual behavior in death. So it's very important to assess the infectious disease possibilities.
Ma'am, also after collecting the blood, compatibility test is given the most priority. Can we know why?
Compatibility test starts with the blood request. So the clinician plays an important role in this. So they have to know which component the patient needs and how many units the patient needs, and moreover, whether the patient needs blood or not. So this is very important. So because random utilization is not advisable. So if the patient needs blood, then only it's required to give that. So first, at the time of request, you assess the patient details, HB, and the patient diagnosis, what is the primary diagnosis and what is the cause for anemia, what is the need for giving blood, so everything. Then with the request, what component the patient needs. So the request is important. So first you verify everything and then you assess the sample also. You receive the sample, labeled sample. So from the patient side, you receive the request and the patient sample. Then after assessing the report, which blood group or which component the patient wants, then you, from the stock register, you select a particular unit which is at near expiry. That is first and first goes like that. So you should not randomly select the blood. So actually it will be in that order. So you have to select that. Select a particular blood bag and check in the register whether it was screened or not. So if it is screened, then you select a particular unit. So first thing is receiving the requisition and check the sample for the identification of the patient ID, everything. Then selection of blood bag from the stock register and checking the screening report. The third thing is checking the blood group. Blood group of the patient and the blood group of the blood bag. So you have to check both this. If the patient is B positive, you check the B positive, whether both coincides, the patient sample and the blood bag sample. If both groups are okay, then you proceed with the compatibility test, otherwise called as cross-matching test. So the cross-matching test involves major and minor. So in major, they will mix the patient serum and donor's RBC. And in minor method, they will mix the donor serum and patient RBC. So they will mix both this and they will check for the reaction, antigen-antibody reaction. So after the incubation period, if there is no reaction and there is no agglutination and all, the blood is suitable for transfusion. So there are so many procedures available. You can do it in a test tube method, that is immediate spin method in a test tube, or you can do it in a gel card also. Now the gel card is available. They are doing in a gel card method. So this is about the compatibility test.
Yes, ma'am. We completely understood the concept. And next, ma'am, how important it is to report the transfusion reaction rates, just because in the year of 2016 and 17, in complete India, we got around 4,200 cases. So how important it is to report the transfusion reaction rates?
So about the transfusion reaction, so the first thing is, so you can classify the transfusion reaction into acute reactions and chronic reactions. So acute reaction means which occurs within 24 hours of transfusion. So this is acute reaction, and chronic reaction means after 24 hours, a few days or weeks or months also. So this is chronic reaction. So in acute reaction, again, you can classify into immune-mediated reaction and non-immune mediated reaction. So immune-mediated means due to antigen-antibody reaction. So this is immune-mediated. So in immune-mediated reaction, you have this allergy, anaphylaxis, and the hemolytic reaction, and TRALI. TRALI is otherwise called as transfusion-related acute lung injury. So all these and febrile non-hemolytic reaction. So all these are considered as acute immunologically mediated reaction. And in acute non-immune reaction, so acute which is occurring within 24 hours but not due to antigen-antibody reaction. So here comes the volume overload. So this plays an otherwise called as TACO, that is TACO, transfusion associated cardiac overload. So this is acute reaction but non-immune mediated. And hemolysis due to non-immune causes. So hemolysis can not only due to antigen-antibody reaction, hemolysis can occur due to physically mediated, chemically mediated, and mechanical hemolysis. All this can occur. Physically means if it is not stored in a proper storage, if the temperature goes high or low, it may lead to physically mediated. That is, temperature plays an important role here. So it results in lysis. Chemical means you should not infuse any medicines through the transfusion set. So it results in chemical lysis. And mechanical means if you're transfusing through a very small bore needle or using some pumps or processing machine and all, it may lead to mechanical hemolysis. So all these are non-immune mediated hemolysis. So you can get the volume overload and hemolysis due to non-immune causes, hyperkalemia, citrate toxicity, and this hyperkalemia. All this are non-immune mediated acute reaction. Then about the chronic reaction. So in chronic reaction, the common reaction is transfusion mediated graft versus host infection. So the disease. So this is delayed reaction due to immune mediated thing. And the other one is post transfusion purpura. So this is also delayed reaction. After a few days or weeks only this reaction may occur. And in chronic reaction, non-immune mediated is the main role is played by transfusion transmitted infection. So this is also TTA, that is transfusion transmitted infection, is also considered as an adverse reaction for transfusion only. It may occur a few weeks or months after the transfusion. So one is this infection, the other one is iron overload, that is which results in hemocytosis also. So this is also considered as delayed reaction. So this is according to this timing, acute and chronic classification. Apart from this, you can classify it into mild, moderate, and severe reactions. So in mild reaction, the main symptom, that is the main thing, is tachycardia. So this is the common reaction where most of the patient complains of tachycardia only. So 1 out of 100 or 200 transfusion, at least one patient will get this tachycardia, that is rashes. So the patient may complain of itching or flushing sensation, some burning sensation. So this is the very common reaction reported by the patient. And the main reason for getting this acute, that's tachycardia, is hypersensitivity. So hypersensitivity due to the foreign proteins which is present in the transfused blood. So this plays an important role. So when a patient gets tachycardia, since this is a very common reaction, when a patient gets tachycardia, you immediately stop the transfusion, and the first thing is you have to inform the consultant, that is the main treating person, and the blood bank also. So you give the donor, you give the patient mainly the Avil, you wait for some time, or you slow the transfusion, wait for some time, and if the patient is comfortable, you can slowly start the transfusion again. Or if it worsens or not subside, means you stop and disconnect the transfusion. So this is in case of mild reaction only. So only the urticaria comes in this mild reaction. So you can continue the transfusion if the reaction subsides within 30 minutes. Okay. Then comes the moderate reaction. So in moderate reaction comes the fever with chills and rigor, and the tachypnea, dyspnea. So all these are moderate reaction. So the moderate reaction is also due to hypersensitivity only. So hypersensitivity due to leukocytes and proteins. The main role is played by the leukocytes here. So the leukocyte mediated reaction and TRALI, all these are this leukocyte present in the transfused blood. So here also you can stop the transfusion, give antipyretics and give medications. And if the patient is comfortable, can continue with another unit of blood. Or if the patient is not, if any reaction is not subsiding, then you discontinue the transfusion. So in this type, you have to try with another unit of blood only in this moderate type of reaction. And the severe reaction is otherwise called as life-threatening reaction, that is which may cause death also. So in this comes the hemolytic reaction. The hemolytic reaction is due to mismatched transfusion, that is giving a wrong blood for a patient. So mismatched transfusion may result in hemolytic reaction. And the TRALI may also lead to death. Transfusion-related acute lung injury may result in bilateral pulmonary edema, and it may be life-threatening also. And anaphylaxis, severe anaphylaxis may result in transfusion also. So this may lead to death also. And the volume overload.
Yes,
Volume overload also plays.
Ma'am, also, is there any way that we can stop these reactions, like these blood transfusion reactions?
So these are the common reaction. You can prevent the reaction. That is, you can avoid these reactions. Certain reactions you can't prevent, like hypersensitivity reaction and all. So the hypersensitivity reaction can occur even with compatible blood, because it's just a hyperimmune response by the patient. So hypersensitivity you can't prevent, but otherwise other reactions like this taco, trally, and the hemolytic reaction due to mismatched transfusion. So you can avoid all these reactions. So the main thing you have to follow is right blood, right patient, and right monitoring. So right blood means at the time of issue, you have to check whether the blood bag is the correct unit for the patient. You have to check with the patient blood sheet and the blood bag. So we check the blood bag, whether it is a required component by the patient and whether the blood bag is suitable for transfusion. It is not clear without any lysis and without any leakage, contamination, nothing is there. So first you check the right bag is the bag is okay. Then the right patient. So the right patient is identification is very important. So double identification is very important. So you have to check with one more person, either your colleague or a staff nurse in the ward to check for the identification. So both of you, two persons should check before starting the transfusion. You check with the identity of the patient, with the patient's name. If the patient is conscious, you can ask the patient name by herself also. You check it, and whether it is clear, then you start the transfusion. And the proper monitoring, complete monitoring of the patient is also important. So all this regular, that is right patient, right bag, and the regular monitoring, all this plays an important role in preventing the transfusion reaction. And in certain patients who's getting repeated reaction, you can select suitable component. Example, if the patient is getting repeated reaction for a hypersensitivity reaction for glucose, so you can select the leukocyte. So you can select specific component if the patient is reacting to some.
Ma'am, and also many wants to know, how do we facilitate the blood in emergency situations like road accident or even the emergency surgeries? So how do we deal with these things?
So so usually in any elective surgeries, they'll reserve for blood. Okay, so if at all needed, they will utilize. Otherwise, they won't utilize the blood. So this is just reservation. In other cases, they won't reserve the blood, but due to some unexpected bleeding, they may need blood in the theatre. So in those cases, if they know the blood group of the patient, they can ask for the specific blood group in emergency. So one is you can do the immediate spin method and issue the blood within 5 minutes of the specific group. And if it is very urgent, there is no time to do the cross matching also. You can issue the same group blood without cross matching also. So without cross matching, you can issue in emergency if you know the blood group. Okay. And the third thing is, if you don't have time to do even if you don't know the group of the patient also, in that case, example, as you said, in road traffic accident and any major trauma or any major casualty, if the patient is shifted to the theatre without knowing the blood group also, if they need the blood immediately in the theatre, you can do this, that is, go for this universal donor concept. You can give any, that is O group in this emergency situation. So any number of O group can be given for the patient if you don't know the group of the patient in emergency. Otherwise, if it is a female or if O negative is available, it is better to choose the O negative blood group in emergency situation, and you can transfer safely. The O negative is very safe than O positive. So O negative can be given in any emergency if you don't know the group of the patient. If you know the group of the patient, AB positive is considered as universal acceptor. So if the patient is AB positive, and if you don't have AB positive in the blood bank at that time, so AB positive can accept any group. So if you have A positive or B positive, you can transfuse A positive or B positive, so or AB or O. All the groups can be accepted by a AB group patient. And if O positive is available, you can give O positive also. And if nothing is available, that is, if blood is also not available, means it depends on the percentage of loss. So you can assess the blood loss percentage in that case. So blood is needed only after if the loss, that is, if the loss is more than 30%. If the loss is less than 10%, no need to transfuse also. So if it is less than 10%, just we assess the percentage of blood loss in RT and any other major surgery. So if the loss is less than 10, you go with fluid replacement. If it is 10 to 20%, then you replace with, that is 10 to 20%, you replace with saline and all. If it is more than 20%, you go with plasma substitutes like crystalloids and colloids. So this will do. If it is more than 20%, you replace with plasma substitutes. Colloids means the dextran 40, dextran 70, hemosil, all this, and crystalloids, ringer lactate solution, Hartmann solution and all. And if the blood loss is more than 30%, then you go for blood transfusion. That is mainly the whole blood transfusion is indicated only in case of hypovolemia or hypotension. Okay, so you assess the blood loss and then plan for transfusion. If blood is not available and the loss is only minimal, you can replace with plasma substitutes also.
I can surely say this was going to be my best session ever, ma'am. And now let's break some myths, ma'am. Like, let's start for the first one. The first one is like the fresh blood is more better than the stored blood. So how do you comment on this, ma'am?
Fresh blood means the blood which is collected within 7 days. With the 7 days old blood is called as fresh blood. Fresh blood is indicated only for certain cases, like in newborns and cardiac patient, kidney disease patient, and so for these patients, the fresh blood is needed. Otherwise, stored blood is no need to give fresh blood for all the patient. So the stored blood, you can give stored blood also. That is up to 35 days, up to 35th day midnight, the blood is suitable for transfusion. So maximum 60 to 70% recovery will be there, even for the stored blood. Not necessarily every patient should get the fresh blood. Fresh blood would be reserved only for few indicated cases.
Yes, ma'am. Also, there is a myth that do the patients who donate the blood lose their immune power or lose their health?
Affect the immune system actually. Usually, blood donation plays.
And health.
It has so many benefits for the donor. But actually, if a donor is a regular donor and if he is donating regularly, the cells are regenerated very frequently. So he is getting fresh blood and fresh, all the cells are fresh. So it's like that is main freshness, everything. And actually, the cholesterol level, everything will be in check if a donor is a regular donor. And the calories around, for each donation, around 500 calories will be burned by a donor. So there are so many advantages in this. And moreover, you are getting a physical, main free medical checkup, and you are getting all your infectious disease screening, everything. So there are so many benefits in giving blood donation. And it's actually not true. The immune system, so actually
Yes,
it's not like that. There are so many benefits in giving blood donation.
Ma'am, the third myth goes like this, that the diabetic patients cannot donate the blood. So what will be your comment, ma'am?
Diabetic patient, if they are insulin dependent and if they are having any vascular diseases like peripheral neuropathy, and if they are having any other complaints like neuropathy, nephropathy like that, they are not allowed to donate blood. Otherwise, if a diabetic patient is having blood sugar under control, and if he is on oral hypoglycemic drug with normal blood sugar and no complications, even a diabetic patient can donate blood. So there are two categories in diabetes. One is a diabetic patient on oral hypoglycemic drug with normal blood sugar can donate, and diabetic patient on insulin is not allowed to donate. Okay, diabetic patient on insulin is not allowed to donate.
Also, the person who is taking the antihypertensive drugs, is he eligible to donate the blood?
Antihypertensives also the same as diabetes. If they are on regular antihypertensive treatment and if the BP is under control and without other complications like any history of angina or obesity or dyspnea, without any of the complications, and if his BP is under control, that is the maximum limit is 140/90. If it is less than this, and on regular treatment means an antihypertensive can donate blood. But if the limit is it's not under control means can't donate. Otherwise, both diabetic patient and hypertensive patient, if the sugar level is within control and on regular treatment, and if the BP is under control and on regular antihypertensive patient treatment, both of these patients can donate blood.
Ma'am, is it true that the patients who are having autoimmune disorders cannot donate the blood like rheumatoid arthritis?
Autoimmune diseases. Rheumatoid arthritis patient can't donate blood. So severe arthritis patient, ankylosing spondylitis, systemic lupus erythematosus, dermatomyositis. So all these patients, all these autoimmune disease patient case are not allowed to donate blood.
Also, ma'am, during this pandemic days, a lot of patients saved their life just because of the blood transfusion. So now we want to know how COVID made the changes in the protocol of transfusion of blood, and can the positive patient can donate the blood?
Okay. Okay. So during this COVID, you have to get the details from the patient, whether he's not suffering from any of this fever or cough or any other symptoms. And so if he has had COVID during the previous period, you can collect from a COVID affected patient also, provided that he is completely recovered from the symptoms, and 28 days after the complete recovery, he can donate blood. So 28 days only. For dengue, chikungunya and all, they are taking mostly 6 months only. After that, they can give. But in COVID patient, after the complete recovery, after 28 days, a donor can donate blood. And even this is same for vaccination also. Now, most of the donors are coming after vaccination also. So for a vaccinated person also, after the dose of vaccine, whether it is a first dose or second dose, if he completed second dose also, after 28 days of vaccination, a donor is eligible to donate blood. So this is the main guideline we are following, and no need to do the COVID test also. So this is not indicated. The COVID screening is also not recommended by the government also. So you can collect the blood, and you have to get the consent for that also. If the patient, if the donor was affected with, that is after donation, if he complains of any positivity, he has to inform the blood bank. That you have to inform to the donor. So you can collect from affected patient after 28 days, and after 28 days of vaccination, a donor can donate.
So, ma'am, we are done with the questions from my side. So now this is the doubt section from the audience. So we'll go one by one, ma'am. So, ma'am, the first question is like this: do the genetic disorders of the donor affect the patient?
Genetic disorders won't affect the recipient.
Yes, ma'am. So, ma'am, the next question goes like this: that a patient after recovering from COVID virus, how much time, in which period he can donate the blood? So, how would we deal with this, ma'am?
There is no specific indication. From the donor, after 28 days, they can donate. Patient, there is no specific indication. They can receive the blood at any time if they need.
So, ma'am, what would be the renal complications after incompatible blood transfusion? So,
renal impairment may occur in hemolytic reaction. That is, in mismatch to transfusion, the blood is hemolyzed during the antigen-antibody reaction. So most of the degraded products are excreted there through the renal system only. So the patient may go for acute, that is hemoglobinuria occurs. Hemoglobinuria may proceed to oliguria, anuria, and complete acute renal failure may occur during the hemolytic reaction. So once you suspect severe hemolytic reaction, you have to check your that is renal parameters and the urine sample for hemoglobinuria. So if the so they may go for the dialysis also if the renal parameters are very severe. So you have to treat the patient immediately. That is supportive treatment is needed. Then you have to give the continuous treatment to alter the renal parameters. The renal parameters may get altered in hemolytic reaction.
yes, ma'am. Ma'am, ma'am, also, can you please say the order of systemic organs which are getting damaged due to the incompatibility?
First thing is the hemolysis. So immediately the coagulation, the DIC may occur. So it results in severe bleeding. The coagulation profile may get altered. So at the time of surgery, that is if the reaction is very severe, so the patient may get bleeding even from the transfusion, that is injected site. From the needle point itself, the patient may start bleeding. And if the patient is on the table, because of the altered profile, the bleeding may be so severe, and the degraded hemolyzed product may get excreted in the urine, and the urine color may change. So mainly the renal system is affected immediately. And so the hemoglobinuria may result during this process. And because of hemolysis, the cardiac function is also affected. It results in severe hypotension and tachycardia, everything. So these are the main thing: hypotension, tachycardia, DIC, and altered renal function, acute renal failure. So all this may occur due to severe hemolytic reaction.
Ma'am, also can you share the rare or interesting case of blood transfusion?
Is not rare, not transfusion, but we come across some Bombay groups actually. So I think you are aware of that Bombay group. So luckily, so Bombay group was it's O positive group. Actually, it's O positive only. When you do a special test only, you can know that it's belong to Bombay group. So luckily, the patient doesn't need any transfusion at that time. So at the time of compatibility only, we detected that the patient belonged to that Bombay group. And we had a donor also. So we come across a donor. So we collected the blood actually. After doing the test in the lab only, we come to know that the donor belongs to Bombay group. So we kept that blood for 35 days. So we had a donor at that time. So we reserved the blood. We asked the donor to come at the time of delivery. But the patient doesn't need blood at the time of delivery. We send the donor. So it's very difficult to manage like this rare blood group. So we didn't transfuse at that time. So this is a difficult situation we come across during that period. So the patient was in labor at that time and she belonged to that Bombay group. So we did cross matching. No blood was that was compatible for that patient. So we come to know that the patient belonged to the Bombay group and we searched for the donor. We kept the donor ready at that time. We didn't bleed that. So this was actually that difficult situation we faced so far. Otherwise, other components and all we can manage. So that depends on the availability. So the Bombay group management is very difficult according to us.
Ma'am, also there is an interesting question. After during COVID, if the patient is transfused blood, the oxygen carrying capacity of blood, do it increase or like what would be the change?
Oxygen carrying capacity not that is extra is not correct. Actually, this everything is same only. Whatever that is, it depends on the time of collection. If the blood is fresh, so the oxygen carrying capacity will be good. So if you want to transfuse a patient with more, that is actually the 2,3-DPG, 2,3-diphosphoglycerate plays an important role in oxygen carrying capacity. So this will be maintained up to a maximum level in fresh blood. So if you want a patient to get more oxygen carrying capacity and all, it's better to choose the fresh blood. So it depends on the selection of blood. So you select the fresh blood collected within 1 week for the patient. And you can give fresh blood also. Fresh blood within 24 hours carries all the component. So fresh blood will do that. Not all the blood. If you want more oxygen carrying capacity, you go with fresh blood.
So ma'am, finally, do you want to share any personal experience of yours?
Thing is to prevent the mismatched transfusion. So all of you has to take maximum responsibility during transfusion because so in my experience, it's better to do single-handed. So you collect blood from the blood bank, you do the identification with the patient and cross-checking with another and do the transfusion by yourself. Never leave the donor patient at the bedside without any monitoring and all, because this plays an important role. The misidentification of patient is very, very dangerous, because if you hand over the transfusion to some other person to carry over and the identification is not proper, that may lead to very severe reaction. So you do the transfusion with utmost care and you take the full responsibility if you are doing the transfusion. And always it's better to do the transfusion in the daytime. In emergency, you can go with transfusion in the night. Otherwise, it's better to complete before 5 o'clock and 6 o'clock. It's better. Does COVID be transmitted by? No, it was not so proven that it can be transmitted through blood. Since it's a respiratory virus, so far there is no cases that is reported that it's transmitted through blood. And it's given in the guidelines also. It's not so far transmitted through blood. So you can, that's what we have, that is put up the guideline that you can collect from a donor after 28 days also. Even it's not transmitted.
Thank you so much, ma'am. It's such an honor to be with you here. And literally, this was being the best productive session of mine till now. Thank you so much, ma'am.